All right, everyone, we're going to go ahead and get started because it's 12:05, and I don't think this conference will take the full hour, or it should not. So hopefully you guys have a little bit of extra time afterwards. So first off, it's just a quick announcement. In 2 Thursdays from now, so December 10th, we're going to have our first basically multidisciplinary conference with radiology and family medicine. The point being, we want radiology to basically help us learn how to become better at reading images. And so if you guys have any cool imaging studies of the chest over the next 1 to 2 weeks, please send those MRNs to the chief at your site, and we'll pull sort of the best ones together for radiology to teach us. And it's going to be great. All right. So getting into the conference, we're going to do a little Thanksgiving medical adventure today. And we've got 3 mini cases that we're going to go through, which are all sort of tangentially related to Thanksgiving. So before we start off, in the chat, if people can just throw in who they think drew this turkey. Oh, Amelia jumping in first, saying that she thinks Corey drew this. Corey saying I drew it. And the correct answer is one Corwin McGee. This photo taken during a Zoom conference from earlier in the year. It's hard to be unhappy when you know that this picture exists in the world. All right, so let's get into the conference. So our adventure is going to begin with the Griswold family here. We're going to take a little tour, get to the family meal, and then go from there. So our first mini case involves traveling to visit your family. This is sort of in the before times, before COVID happened, and all of us were probably going to travel this Thanksgiving. But now that we're doing it here, we'll sort of simulate that. So the ED calls you at Denver Health and says, I've got a guy who might have ARDS and he needs the MICU. You look at his vitals. He's afebrile. His heart rate's 105. His blood pressure is 130/70, and he's setting 70% on room air. He gets put on 5 liters and gets to 90%. These are his relevant labs. I've highlighted in red the abnormal ones. His white count is slightly elevated at 11.4. I think everyone is probably waiting for the chest x-ray. So here it is. He's got his AP on the front and his lateral on the side. I want everyone to take about 20 seconds to take a look at this, and then I'm going to ask someone brave to read this. All right. So if anyone wants to volunteer to read this out loud over the audio, that'd be great. Otherwise, people can just type in the pattern they're seeing into the chat. Any volunteers?
I think chat is unfortunately disabled.
Oh, interesting.
But Amelia is working on it.
Cool. Yeah, I'm trying to play with Zoom.
Chat is disabled. Strong start for all of us. Amy, because your audio works and you just said that out loud, I apologize, but do you mind just taking a quick read of this?
Not at all. I would say this looks like a sort of patchy, fluffy alveolar type infiltrate pattern.
Perfect. Yeah, that's a great, really succinct read, and I completely agree. So, patchy alveolar infiltrate, and what portion of the lungs is this sort of most concentrated in?
I'd say in the middle lobes.
Yeah, awesome. So middle lung fields, patchy alveolar, and I'm going to give you a little bit more history. This is a gentleman who drove from Oklahoma to Leadville, Colorado, which if you guys are not familiar is at 10,151 feet without stopping in order to see his family for the holidays. And so in the chat, if anyone wants to throw out what diagnosis they now are working with. Perfect. So Team A says this gentleman has HAPE, and they are exactly correct. So our first mini case involves HAPE. And so if we go to the Zoom whiteboard here, which we have not done in a while, but let's talk about, that's my mountain, kind of. We're going to talk about HAPE. That's a terrible mountain. All right. So the pathophysiology of HAPE, it's essentially due to a problem of hypoxic pulmonary vasoconstriction. And this process essentially becomes altered and functions inappropriately, which ultimately leads to basically PH or pulmonary hypertension, and then alveolar infiltrates. And if someone could throw in the chat, how do we treat HAPE? Perfect. So Sam hits it on the head. So the first thing you want to do is, if the person can descend, you want to tell them to descend. And that's perfect. And that's often the thing that does it. Amy, hitting all the ABCs there, says you want to give them supplemental oxygen, which is exactly correct. And then let's pretend that this person, they descend to a lower altitude, they get supplemental oxygen, and they're still feeling poorly. Are there any pharmacologic therapies that we can give them? So VA Team A says acetazolamide. We've got Dylan Herman saying promethazine. I like it. People are taking chances. So those are great. Those are options that Corey throws it in acetazolamide. I like it. James Duffy says calcium channel blockers. All excellent suggestions. So the only thing that we really know actually works, and the data isn't perfect for it, is nifedipine, which is one of our non-selective calcium channel blockers. So all of the other things that you guys suggested are typically for acute mountain sickness or high altitude cerebral edema. And they've been tried in high altitude pulmonary edema, but they haven't been found to be more effective than placebo or nifedipine. And actually the interesting thing, even though you would think it would work because it's alveolar and it's fluid, is that current guidelines actually recommend sort of against diuretics. So you're supposed to hold off on diuretics in these people and essentially just treat them supportively by descent, oxygen, and nifedipine if they're still symptomatic. Typically, it takes about 24 to 48 hours for HAPE to resolve, but HAPE will often resolve on its own without any sort of intervention. So in our gentleman's case, he gets admitted, he gets obviously descends to Denver, so he descends about 6,000 feet, he gets oxygen, he gets nifedipine, and he feels better and discharges. Would you guys give this person dexamethasone? Throw in the chat yes or no. Ward says no, and that's correct. So dexamethasone, not recommended for HAPE, but recommended for HACE, high altitude cerebral edema, or acute altitude or acute mountain sickness. So essentially dexamethasone, if you think this person has true ARDS or COVID, please treat them with that. But otherwise it's for HACE or AMS, acute mountain sickness. All right, any questions in the chat about high altitude pulmonary edema? So Amy did a fantastic job reading that chest x-ray. And so just to really hammer home, what are these sort of imaging findings for high altitude pulmonary edema? So these are your lungs. It's a pretty terrible picture. Yeah, so Sam asks, is there any evidence for non-invasive in HAPE? Yes, there is. And so if the person is failing nasal cannula and still having sort of an increased work of breathing, then putting them on either heated high flow or non-invasive, similar to other people with respiratory failure or respiratory distress, has been shown to be beneficial. So great point. And so if your person is failing nasal cannula, still working hard to breathe, please escalate like you would for a really severe pneumonia or really severe heart failure or ARDS. So this person has high altitude pulmonary edema, and Amy called it out. She said that there's alveolar infiltrates, right? So there's sort of this fluffiness scattered throughout both sides. And it is most prominent in the middle lung fields. So it's most prominent in the mid lung zones, and it typically starts on the right side, which I can't give you a good answer for why, but then it progresses to the left. And notably, high altitude pulmonary edema sort of spares the peripheries. And so this gentleman, we'll go back and look at in a second, but he actually has one of the classic x-rays for high altitude pulmonary edema because he has a central alveolar infiltrates with subpleural sparing. All right, so that's HAPE. HAPE in a nutshell. Any additional questions about HAPE, the pattern, the treatment, etc.? I was scanning to see if we did any pulmonologists on the call, but it does not look like we do.
Danny.
Yeah, Amy asked about any role for hyperbaric. That's a great point. So yes, there is a role for hyperbaric therapy if your center allows it. And so I think a few of the mountain EDs have small hyperbaric chambers where they can do this. There's some like portable hyperbaric therapies you can bring along, which I'm sure are super expensive. But yeah, there is a role for hyperbaric therapy in addition to non-invasive and heated high flow if your center allows it. And that goes along with sort of a complicated pathophysiology where it's essentially like hypobaric or hypobaric hypoxia. Cool. All right, so let's get back to our PowerPoint here. So just to hammer home, we look back at this gentleman's X-ray, and you can see, right, he's got these central alveolar infiltrates, so that fluffiness, maybe some lines showing he has some interstitial opacities as well, but the outside of his lungs looks relatively clear on both sides. And then he also has a really nice example of the spine sign on a lateral chest X-ray. So as you scan down his spine, it should become more black or more dark. And you can tell at the bottom there is still more alveolar. So essentially it's sort of diffusely spread throughout the sort of the posterior regions of his lung. All right, so our adventure continues. My free time this morning, I found a clip art of the Griswold family vehicle. This is from one of the movies. And then I also just animated because I don't know what I do anymore. So our adventure continues to the turkey. So this is a patient that I admitted this past week when I was attending on wards with my team. And so, right, we start Thanksgiving by traveling to see our family, and sort of the main part of it is the bird. And UCH wards, I don't know if they're complimenting or hating on my animations. All right, so chief complaint for this person is abdominal pain and fever. It's a 37-year-old woman with no significant past medical history, coming in with 3 to 4 days of fever, followed by cramping abdominal pain, nausea, vomiting, and non-bloody diarrhea. Her abdominal pain is generalized, constant, and she says she has cramping flares. She's febrile to 38.5. She's tachycardic to 115. Blood pressure is 125/65, setting 96% on room air. You check her labs because she's still sitting in the emergency department. Her white count is 24.3. K is a little low at 3.5. Her bicarb's a little low at 19. Her lactate is 3. Her ESR is 33. And her CRP is 292. I'll let everyone just take a look at that for a second. And she already has a CT abdomen pelvis ordered in the ED prior to coming up to the floor. And here's her CT scan, which I will now play. All right, I'm gonna play that one more time. And while it's playing, I want people to throw into the chat any prominent abnormalities that they notice on this CT scan. All right, so what are you guys seeing? If anyone wants to just talk via the audio, feel free. And I will pick sort of a slice. Yeah, so Sneha says the colon looks lacy and weird, which I think is probably an apt description. I don't know if that tracks with radiology, but just another plug for our future radiology series. So I think this is a good representative sample. So Sneha says lacy and weird. Anyone else have any descriptions for this?
I don't know how to describe that either. but it also looks like some small batch in addition to, I'll agree with Sneha. I don't know how to describe that colon.
Awesome. Sam, can you say the first part of that again? You sounded a little bit like T-Pain.
Sorry about that. I said, I don't know how to describe that colon either. It looks different than anything I've ever seen before, but I also think whatever's going on in the colon.
Nice. So yeah, so Sam says the colon looks weird. I think in someone in the chat put, does she have pancolitis? And that's actually exactly what the read showed. So both Sneha, Sam, and I think it was Jordan were correct that she had diffuse wall thickening involving the colon, with associated inflammatory changes, but no bowel obstruction, and they called it pancolitis. So how do we actually look at these CTs? And so I know when I was a medical student, I was always concerned about, like, you know, I knew radiologists ran the bowel and sort of looked at all the bowel, and that's actually sort of impossible, I think, and that's not our job as residents. But if you start down towards the bottom of the rectum, which is right here, you can actually trace backwards the colon. So like Sneha said, sort of lacy, weird, there's some thickening, you keep tracing backwards, and you sort of keep seeing this sort of lacy, weird thickening as you go. So now you're sort of in the descending colon in the lower left quadrant, you see the same thing. And then as you cross, you end up seeing the exact same, or as you go up, you keep saying the same thing, lacy, weird, and then you eventually cross over and say the same thing. So the way I was talking to my team about this last week is that sort of fat stranding or inflammation around the colon is sort of similar to ground glass that we see on a CT. It means that there's fluid at sort of that small cellular level, which is coming from somewhere. And in the abdomen, that fluid's coming from inflammation. So this person has pancolitis, and those labs and sort of history findings we just talked about. All right, this is where the case gets good. I personally think this is the best social history I've ever seen taken. So a huge shout out to Katie Yamamura, Divni Mandair, and Zoe Panchal, our team last week, who took the social history. So here's the social history. I'll just put it in a sentence and I'll read it. This is a 37-year-old Dutch dairy farmer who cared for a sick calf with a diarrheal illness 1 week ago, drank raw milk a week ago, ate raw chicken 4 to 5 days ago, and routinely eats raw ground beef with onion. And then she said, it's a Dutch thing. So if anyone feels comfortable, there are a lot of exposures in this sentence. Throw out in the chat or out loud what illnesses you are concerned about. So someone mentions, does the raw onion kill the bacteria? Yeah, that is what we were told. It doesn't. So we got, Leela said listeria. Sam King is saying she's concerned about Campylobacter. VA Team A is saying Salmonella, E. coli. Awesome. And then brucellosis, great. So we're really hitting on it. I've never seen brucellosis, but I love talking about it. We got Q fever from Melanie. I like it. You guys are doing awesome. So these are like the big causes of sort of infectious diarrhea and abdominal symptoms with these exposures. So the sick calf, the diarrhealness, the raw milk, the raw dairy products, the raw chicken, and the raw ground beef. All right. So as the astute intern and resident, you send off your GI PCR, and the GI PCR is positive for Campylobacter. So this woman has Campylobacter pancolitis. I pretended like with my team that I knew what I was talking about when I talked about Campylobacter pancolitis, but I'd never seen this before. So let's talk a little bit about Campylobacter. All right. So Campylobacter, throw in the chat what the risk factors are for getting a Campylobacter infection. I like it. That was a lot. That was a great response. So I'm going to try to summarize it all quick. So basically being a Dutch farmer, I think that's fair. Water. I think I heard someone say dairy in the chat. And I think I might have seen chicken, or I'm just assuming that, or chicken / poultry. And then Amy is saying any sort of animal exposure, domestic, et cetera, which is great. So animals. Perfect. That's an awesome summary. I think the Dutch one, that's my recency bias. Maybe all Dutch farmers have Campylobacter. But yeah, so water exposures, dairy exposures, chicken and poultry, and animals. So once you have Campylobacter, what are the symptoms? So these people typically present with a non-bloody diarrhea, but it can be bloody, so it doesn't really help you, but it's a non-bloody diarrhea sort of approximately anywhere from 3 to 7 days after exposure. So depending on when you're exposed, you're asymptomatic for a little bit of time, and then you develop this non-bloody diarrhea. And then the next thing I want you guys to do, it causes this sort of colitis picture, and it can cause sort of a foodborne illness, but what other weird symptoms or weird findings is Campylobacter associated with? Throw those into the chat as well. Great, so Jonathan is saying it's associated with Guillain-Barré, so GBS, perfect. VA Team A is saying it's associated with reactive arthritis, which is perfect as well. Leela saying Reiter syndrome, sort of the another name for reactive arthritis. Awesome. Yeah, so long-term complications of Campylobacter, Guillain-Barré syndrome, and reactive arthritis. So counseling your patients that even if they get through their current exposure, they are still at risk for both of these things. Interestingly, so pancolitis, like this patient had, is actually pretty uncommon complication of Campylobacter. And then another weird complication, which I think we all learn about in med school and never see again, is the pseudoappendicitis. And so essentially Campylobacter causes you to have symptoms completely similar to appendicitis, but then when you image them, their appendix actually looks okay. So Campylobacter, these are the big risk factors: symptoms, the weirdness of Guillain-Barré, reactive arthritis, pancolitis, and pseudoappendicitis. Most importantly, how do we treat Campylobacter? Throw in the chat what antibiotics you guys want to use. Great. So Sneha and Brandy actually beat me to it and said fluids and time, which is great, which sort of generally falls into that big umbrella of supportive care. And so if your patient is not in the hospital or is in the hospital and is doing okay, this is actually your preferred method of treatment. It's just giving them fluids, giving them time, and almost everyone will recover and feel better. I think someone also just said that they wanted to also think about using azithromycin. So azithromycin is your preferred antibiotic for the very sick. Another thing that you can use, but there's a little bit more resistance, is your fluoroquinolone, so FQ. Notably, and sort of the thing that we all learned the day this person got admitted, is this is not the patient where you can use ceftriaxone and Flagyl if they're very sick. And the reason for that is that Campylobacter or Campy is resistant to beta-lactams. So even if this person has, even if they're doing well, the ED started ceftriaxone Flagyl because they were concerned, you can comfortably discontinue both of those medicines the second they get admitted and either start them on azithromycin or just choose to treat them with supportive care. I think Leela asked, how common is Campylobacter infection? And I'm going to be completely honest with you, I have no idea. This is the first time I've seen Campylobacter in residency. I'll defer to anyone else in the chat if anyone else has seen Campylobacter. But I think most people who probably get this don't need to be hospitalized, which creates sort of like an admission bias on our part. Amelia says she's never seen it. I implicitly trust anything Amelia says. So I'm going to assume this was the first case of Campylobacter.
Terrible idea.
So Jeremy's saying, from Amy, she's saying that 50% of all infectious diarrhea in Colorado is Campylobacter. So Amy is smarter than all of us. That's now my new favorite fact. And I learned that just now. Amy, can you tell us a little bit more about that?
I'm just sitting here with Jeremy, and that's what he said. That's all I know.
Cool.
I think most of the time it probably doesn't require hospitalization.
Awesome. Yeah. That's really interesting. So, so we all learned something today, that if your person does actually come in with infectious diarrhea, the GI PCR will be helpful because you could identify them as having Campylobacter. All right. So back to our PowerPoint here. I think the thing you guys are probably all most interested in was when I said this was a Dutch thing. And is it actually a Dutch thing? Yes. So these are pictures from a website called the Dutch Table, which is, I think, a reputable source for Dutch culinary. I'm kidding. So this is called filet American, or steak tartare, more commonly. And it's a Dutch delicacy. Essentially, they blend up ground meat. They mix it with olives, various vegetables, and they mix it with raw onion, and they eat it on a cracker or on a piece of bread. It sounds like the Dutch love this. Objectively, I would probably avoid this if I was traveling abroad, just so I did not get a traveler's diarrhea or something else. But when our patient told us that it was a Dutch thing, she was indeed correct. So just another plug for trusting your patients. I'll let you guys look at this a little bit longer while you're eating, just to make sure we're all appropriately grossed out. All right, so final mini case. So we've talked so far about high altitude pulmonary edema. We've talked about Campylobacter. And now we're gonna move towards the dessert. All right, so this case, we're gonna be talking about someone who had too much sugar. So their chief complaint is abdominal pain and nausea. They're a 45-year-old man with type 1 diabetes coming in with generalized abdominal pain, nausea, and shortness of breath the day after Thanksgiving. He forgot to pack his insulin for the road trip. So I think everyone is probably guessing what's happening next. His vitals, he's afebrile, his heart rate's 110, blood pressure's 125/65, breathing 30 times per minute, setting 94% on room air. These are his labs. White count's 14, his sodium is 130, K 3.1, bicarb 10, BUN creatinine 32 and 1.4, glucose 450, lactate's elevated, beta hydroxy's elevated, pH is low. So just so we're all on the same page, everyone throw in the chat what the diagnosis here is. Great, the DKAs are rolling in. So I personally don't think it's ever a bad time to remind us all how to treat DKA, because I think with protocols and everything like that, it's so easy to forget how to manage this. So I've been like jokingly referring to this as like the gospel of Mark Kearns for a little while now, but I think it's true. So we are going to talk about the gospel of Dr. Kearns. So Dr. Kearns has his 5 I's of DKA. And I want you guys to throw in the chat what these 5 I's are, the 5 I's that predispose you to DKA. Great, so Brandy says insulin, which is great. So insulinopenia. So if you are short on insulin, we got impregnation. Claire says infection, which is great. Ischemia. And we're looking for one more here. Iatrogenic. I would probably group with insulin. Amy says iatrogenic. Iatrogenic from, we'll say iatrogenic from taking intoxicants or ingestions. So things like alcohol, drugs, etc., all predispose you to getting DKA. So an easy way to think about working someone up for DKA then, right? So insulinopenia, so right, so you want to take your clinical history and see if they're taking their insulin. Our gentleman didn't pack his. Impregnation, so you want to check a urine HCG if they are a woman of reproductive age. Infection, again, taking your good history, perhaps getting a chest x-ray, blood cultures if the situation calls for it. Ischemia, you get your trope and your EKG if they have a clinical situation that sort of might correlate with that. And then intoxicants, ingestions, this might be one of those times where a UDS is helpful unless the person is very forthcoming and tells you exactly what they took. So I'd be interested to hear from any of the other chiefs or people in the chat if you guys have another system, but this is my system when I'm admitting somebody with DKA is the history, urine HCG, chest x-ray, blood cultures, trope, EKG, and a UDS to sort of rule out all of the causes of precipitants, et cetera, of DKA. All right. So it's one thing to diagnose DKA. It's a whole separate thing to treat it. And so what I'm going to do now, I think I've talked about this in a prior conference, But I think one of the cool things is that, you know, there is DKA protocols, and we can always just click yes on the DKA protocol and go for it from there. But if you are admitting at the VA, there is no DKA protocol, and there may come a time in your life where you don't have a protocol available and you still need to treat someone with DKA. So we're going to create our own DKA protocol here in about 5 minutes. So what I want you guys to do is throw in the chat what 3 big treatments every DKA patient needs. So seeing fluids, I'm seeing insulin, and then I think I saw potassium, which is great. So fluids, insulin, and electrolytes. Those are the 3 big things that every single DKA person needs. So the way I break this down then, so fluids, insulin, electrolytes, you've got sort of the beginning, you've got your maintenance, and you have your ending. And these 3 things right here essentially create your protocol. So we'll start with fluids because that's sort of the first thing. So how much fluid do you want to give this person? And why do we want to give them fluid? Perfect. So Sam says she wants to give 2 liters IV fluid. That's awesome. So Sam says 2 liters of IV fluid, and she's mentioning the osmotic diuresis from hyperglycemia. So these people are also often sort of dehydrated and volume depleted. And so a fun fact, so being low on volume equals sort of increased cortisol, and increased cortisol makes you relatively insulin resistant. And so if you give these people IV fluids, you will actually make them respond to their own endogenous insulin almost immediately, and you'll drop their blood sugar without even doing anything in terms of the insulin. So perfect. So you give them 2 liters of IV fluid, and we'll come back to that one in about 5 minutes. All right, insulin. How much do you guys want to give? It's awesome. So Brandy says 0.1 units per kilogram, which is awesome. And what formulation of insulin do we want to give? Great. Leela says regular. Perfect. This is not the time to do your sub-Q sliding scale. So 0.1 units per kilogram of insulin essentially comes out to basically 10 units for the average size person. And so most DKA protocols or the ED protocol starts with giving these people 10 units of IV regular insulin right off the bat. And then electrolytes, what is the big electrolyte we need to fix before giving insulin? Awesome. So potassium, great. So your K should be greater than 3.3 before you give insulin. So if your K is not above 3.3, you need to replete the K as soon as possible before doing the first 2 things. All right, so we've fixed it. We fixed the beginning of DKA. We've given them fluids, we've given them insulin, we fixed their potassium. We get now to our maintenance phase. And how much fluid do you guys want to give these people per hour? This is one of those times when you could probably pick a number and be right. Great, so 250, David's right. So 250 to 500 cc's per hour, that's perfect. And you're doing that because they've got this ongoing osmotic diuresis and they're all volume depleted. Perfect. All right, insulin, how much do you guys want to give per hour? I'll give you a hint, it's the exact same number here, 0.1 units per kilogram per hour. And you want to drop their blood glucose by 50 to 70 per hour. And then electrolytes, there's a protocol here where the nurses will replete, but essentially these people need about 10 to 20 of KCl per hour. All right, so the ending of the DKA protocol. So you guys have done great. You've given them all their fluids. Leela says, is it harmful to drop them too fast? Good question. It is harmful. So it's not harmful to drop them too fast, but the thing you watch out for is when their blood glucose gets less than 250, you can make them more prone to hypoglycemia. And so you need to add D5. So there's no harm in dropping them too fast as long as you have the D5 on. And then Leela's saying, but no osmotic reasons. No, there should not be. If you are giving them the appropriate amount of fluid and sort of doing the rest of the protocol, there's no osmotic reason why they can't be dropped. I say that, but as I say that out loud, if you drop them by 200 in an hour, that would probably be harmful. So I sort of recant that previous statement. I'll get back to you on that one. All right, so the ending, so fluids, you can eventually just turn those off whenever you're done. Insulin, how do we end the DKA protocol? A more simple way of asking that is how long do you want to wait after starting your basal insulin? Before shutting off that drip? Great, so Sam says 2 to 4 hours. Snea says 2 hours, great. So you start your basal insulin and then you wait 2 hours and then you shut off that drip. And then electrolytes, hopefully you're fixing those as you go and you just need to keep watching. And that's it. So that's essentially the DKA protocol at all of our sites. You give a fluid bolus up front, fluids as you go, insulin bolus up front, insulin as you go, start the drip, start the basal, DC the drip 2 hours later, and then you're repleting your electrolytes as you go as well. So the reason I want to talk about DKA for this particular one is as of this past week, there was a pretty cool article that came out in JAMA looking at whether we should use LR or NS for DKA. So the article was titled Clinical Effects of Balanced Crystalloids, LR versus Saline in Adults with DKA. And so this study is actually the 3 people that I highlighted here are all responsible for the SMART Med trial and the SALT ED trial out of Vanderbilt, the study that looked at LR versus NS for critically ill adults and for hospitalized adults. So these 3 people are sort of on the warpath to end NS once and for all, and I approve of that goal. So what did this study show? So it was a subgroup analysis of the SMART and SALT ED studies. So SMART and SALT ED, like I just said, LR versus NS in critically ill adults and non-critically ill adults, which showed a benefit for LR with a number needed to treat of about 90 to prevent mortality. And their primary outcome was time between the ED presentation and DKA resolution. And so why even choose this primary outcome or why look at this? So LR as opposed to NS. So NS is associated with a hyperchloremic non-gap acidosis. So it checks out that if our whole goal in DKA is to stop the acidosis, close the gap, and raise the bicarb, that we'd like to give a fluid which doesn't make that job harder. And so NS, there's a theory, may make that harder because it causes a non-gap acidosis. So if we can close that gap faster, then we can decrease this time from ED presentation to DKA resolution. So within their sort of greater 15,000 person study, there was 172 adults who had DKA, 94 with LR, 78 to NS. And they showed that there was a shorter time to DKA resolution in the LR group, so 13 versus 16 hours, shorter time to discontinuation of insulin, so 9 versus 13 hours. And their takeaway was that treatment with balanced crystalloids resulted in more rapid resolution of DKA. And so I would argue that at all of our sites now, I think we already do this at Denver Health, but I know the UCH protocol does not include LR for either your bolus or your maintenance fluid. I would encourage you guys to consider when you order your DKA protocol, perhaps switching out that maintenance fluid for LR as opposed to NS, because we have a bunch of data now that suggests that LR is a better fluid overall for all of our hospitalized patients, essentially regardless of their underlying pathology. Any questions about this study or DKA? Cool. Any questions in general? That's all I got. That was my 3 short Thanksgiving adjacent cases.
Great work, Danny.
Awesome. Well, thanks, guys. It's been a pleasure. Everyone have a wonderful Thanksgiving. Please be safe if you are traveling or staying here. The most important thing for all of our chiefs, as I speak for the group, is that you guys come out of Thanksgiving just as healthy as you went into Thanksgiving. And if there's anything we can do to help out with that, please let us know.